Good morning, everyone.
Good morning.
Morning.
How are you?
Alive, how are you?
Aren't we? Yep, we're alive, all right. Yeah, so it's a new system, a new life. We have to just adjust and adapt and, go on. And so many things that changes in life, and we have to continue. So you never know. Hopefully it'll open up soon. So I don't know, but you got to be cautious, no matter what happens. Even if we get to go back to campus and all that. But
Is it looking like we're going to be able to?
Well, we are able to. It's just a matter of the risk. How high is the risk? Are we going to? How can we handle the risk? So need to be careful. And no matter what, even though it's just the number of cases goes down and all that. I think this is like a life-term kind of way to protect ourselves from now on. We should not lay down. We just you have to put those masks on all the time, gloves, wash hands continuously, distance yourself all the time. Yeah, I mean, until you don't hear any almost slim cases that are happening at certain areas, certain regions. But if as far as it's still a pandemic, so it could be anywhere. So yeah. So what do you guys think?
I think you're either on board or you're not.
Mm-hmm.
There's no gray. Either you agree with what's going on or you don't.
You mean the existence of what's going on?
No, just like the whole how some states are opening up, because I'm right by the Wisconsin border, so Wisconsin's totally open. So I mean, but then like I just went down to my apartment in the city yesterday because I needed summer clothes because it's hot,
Right.
and it's like night and day from Wisconsin to downtown Chicago. Like downtown Chicago, everyone's got a mask. It's still all closed down, and like Lake Geneva is totally open, like nothing ever happened. So it's like being right by the border. It's kind of like you have very mixed opinions. Either people are on board or they're like, forget Illinois and we're going up north.
Yeah, I mean, but it's when you think about it scientifically. I mean, we're scientific people. We can't just be irrational about this. What's going on here? I mean, there are people that it's a contagious disease, so you can die from it. Now, your immune system should be, in general, compromised in order to get that. But it happens to anyone. It could. No one can guarantee their immune system. I mean, how can you tell if I can, or you can, or someone else can, and it'll affect you, and it will not affect other people? So, so that's why I say you have to be cautious no matter what. I mean, people are opening up. There's a lot of politics going on in it also, the economy and all that, which makes sense. I mean, you can't sit at home and stay at home. You got to open up, and you have to get people back on track again, to live again. But the seriousness of it, it's a contagious, deadly disease, and I am so glad, though it's retained to the numbers, that it's not really. If we did not take the first initiative steps, with social distancing and all that, it could have been probably worse. I mean, so now going out and being with people. Now, as soon as you're gonna see someone coughing or something, you're gonna freak out a little bit. But you don't want to take a chance. So. I don't know if it's to the extent where everyone should be home rather than just taking a lot of precautions, and people have to be responsible. But unfortunately, a lot of people are not responsible, and when you put them all together, then they cough at each other because no one cares about the other. I mean, you would think that they do, but like you hear about this barber shop that a guy was sick, but he was open because he wanted money, and he was coughing on everybody, and a lot of people got it. So is this responsible? So again, it falls on you being protective and cautious, and we work in hospitals. We work around sick people all the time. We're at risk, but you have to prevent. You have to be cautious and use the PPEs and all that stuff to protect yourself. So you got to do this all the time, outside also and inside. We've done this in hospitals. You need everybody else to do this even outside. And can you depend on everybody doing it? People don't want to be restrained. They don't want to put the mask on. They want to just go back to their own life. And but can you trust everyone not to contaminate, to give it to other people? So it's a fine line. But in my opinion, things should go back, but not to, the way exactly how we were. You got to go back to work. You got to find ways to, but you have to be cautious. You have to, I would say, I would keep masks on if the school opens up again. I mean, that's what I recommend, but, I would say students should keep the masks on, and the seating should be a little bit further from each other, when we get close to each other, we must have the masks on and gloves, and if someone is coughing or someone is sick, should not be in class. They should be, being treated. And as soon as you have any symptom like a temperature or anything like that, you got to get tested, and see if you're positive. So going back to school, I think I'm for it. It's just a matter of being very, very cautious, among each other when we are close. So, and in the medical field, we have no issues. I mean, nurses, doctors, and all that. I mean, we always use these gloves and masks and all that, even at hospitals, and we got to take the precautions, But students that are not in the medical field, that are going to be close and they're going to be around us, they have to accept the idea of putting masks on and washing their hands all the time, and all these things that I mentioned. They should take responsibility in doing it, and the school has to emphasize these guidelines. And if they see somebody that's not going with it, they should let them go home. So, but yeah, I think we'll be fine. I think we'll be fine. All right. Any other questions, concerns? You have received an email from the new tutors. So they will be there for you. They'll be available today and tomorrow for the Pathophysics class test. So contact them. They'll go over the focus points and the study guide with you guys. So join them, and then I'll give them the material for the pharmacology test after we finish the antibiotics. So this will not be until maybe next Thursday or something, the exam. All right, let's go ahead and begin. So, so antibiotics, we started antibiotics in general, chapter 9. Questions?
We don't have any tests this weekend?
For pharmacology?
Or patho, correct?
Patho tomorrow. Thursday and Friday for patho. I'm really told.
No. Okay. No, I don't remember that, but sure.
Yeah, patho. I'll put an announcement on Blackboard.
So farm is next week, you said?
Yeah, we've taken the exam already on
right.
On the respiratory system. So the next exam is this one, the antibiotics. And I just started with this, so I'll try to finish.
I thought we were having it this weekend. Okay.
Well, today is the only day we're meeting, right?
Right.
I'll see if I can finish the whole thing. Then maybe we'll do it this weekend. But I was going to go antibiotic along with antiviral together. as one test because we have a bunch of different antimicrobial that we have to finish. So I'll maybe finish this today, the majority of it, and then I'm going to cover the antiviral also, and then I'll give you the test. So the next test will be probably, I don't know, maybe Wednesday and Thursday or something like that. We'll see. We'll play it by ear. But it'll be next week. Okay? All right, so let's go ahead and go into antibiotics. So antibiotics in general are used for bacteria in general. When we say antibiotics, we use them for bacteria. We have, of course, other antimicrobials like antiviral, antiparasitic, so other antimicrobial that attacks the other microorganisms, but this one specifically, it works on bacteria. So we have different types of antibiotics. We have, their mechanism is a little bit different, how they attack the bacteria. So this image here shows you how most of these antibiotics work. We have certain antibiotics that work on the cell wall of the bacteria, so it attacks the formation of the cell wall. So with that, the classification, most common classifications would be what we call beta-lactams. The beta-lactams are these antibiotics that basically contains some kind of ring structure. It's called the beta-lactam. And that would include the penicillins, cephalosporins, carbapenem, monobactams, vancomycin, and bacitracin or bacitracin. So these are the ones that kind of work on the cell wall. We'll talk about them in general there, and we'll talk about the beta-lactam mechanism soon. So whichever works on the cell wall. Now remember, the bacteria has cell wall and they have cell membrane, right? Gram-negative has usually a thinner cell wall than the gram-positive. So there's somebody have the microphone on. Please turn it off. You know, you can hear the background here. Turn off your microphones, please, everybody. So we have another classification of antibiotics that works on the cell membrane, which is the inner layer of the cell wall. And you know, polymyxin are the ones that can work on the cell membrane. Okay. Then, as we go inside, you're going to find different antibiotics that works at different parts or organelles of the bacteria. We have certain antibiotics that works on the protein synthesis of the bacteria. And if you know that we have, you know, already the bacteria will create proteins in order for it to survive. And it goes through the, you know, the dogma, you know, that we covered, which is replication, transcription, and then translation into proteins. And we use the subunits, the 50S and the 30S, when we translate into proteins. So we have certain antibiotics that works on the 30S and some works on the 50S subunits of the, when we were creating well, so these are ribosomes, of course. So the 50S ribosome or the 30S ribosome. So they work on these ribosomes in general, subunits. So tetracycline works on the 30, aminoglycosides work on the 30, macrolides, clindamycin, lizaloid, chloramphenicol, and streptogramines, okay, well, streptococcus, streptomycin and all that works on the 50S. The other classification would be the nucleic acid synthesis. And we have, of course, you know, we synthesize the DNA and the RNA inside the bacteria. So some of these antibiotics work on the either on the DNA gyrase. Okay, DNA gyrase, if you remember from micro, you covered micro, correct? I'm assuming, you guys? Did you?
Yes.
Yeah. Did you go over these the synthesis of proteins, the different steps and all that, replication and transcription? You did, I'm assuming. So DNA gyrase is the one that actually unwinds the bacteria, the DNA. I'm sorry. So some quinolones works on the DNA gyrase where you prevent it from unwinding, and then it prevents the synthesis of protein, yeah, and then the eventually survival of the bacteria. We have RNA polymerase. Also, rifampin works on the RNA polymerase, which basically causes the RNA to transcribe from the DNA. And the other types, the type bacteria antibiotics that we have are folate synthesis, which interferes in the synthesis of folic acid. That has something to do with the synthesis of DNA. So we know that folic acid and B12 has something to do with the synthesis of the DNA inside the bacteria. So folate synthesis, so sulfonamide and trimethoprim are the two drugs that are used against the formation, against the synthesis of the protein by blocking the folate mechanism. So this is a general image about most of the antibiotics. We have separate ones also that we will discuss. These are just images that you have in your book, which are similar of what I talked about in general, but here they kind of specify where exactly each one works. But you can always look at them as a classification rather than each drug. So keep this picture in mind of where everything works. So let's go ahead into the charts and discuss the different classification of antibiotics. The most famous ones are the penicillins. The penicillins are basically naturally discovered. Penicillin was discovered from, basically the fungus, which was actually attacking and killing bacteria. It was discovered suddenly. It wasn't aimed at. So penicillins in general have a structure that looks like this. So it has a structure that has what we call a beta-lactam ring. See, the lactam ring, in organic, when we talked about lactam, it involves the presence of a nitrogen in a cyclic ring. So we have a cyclic ring here with a nitrogen in it. Automatically it becomes a lactam. So beta-lactam is this structure right there, like a house, and then there's a garage next to it with these different functional groups attached to it. You don't need to know the structure. All what you need to know is penicillins have a beta-lactam type of ring, okay? And that's how it looks like. Because this beta-lactam is very, very important for the antibiotics to work. And basically the beta-lactam of the penicillin, they target the penicillin binding protein on the cell wall of the bacteria. So this house here goes on the cell wall of the bacteria and interferes in the synthesis of the cell wall of the bacteria. The cell wall is made out of peptidoglycan. So peptidoglycan is basically a peptide that is made out of carbohydrate and protein. And this penicillin will come and interfere. It sits at a site where it interferes in the synthesis of the cell wall. And by that, it causes the, it creates like pores in the bacteria where water will go in there, and eventually the bacteria will explode and it will be killed. So we have different types of antibiotics that has this structure, which is the beta-lactam. And it works in with the same mechanism. So we have all the penicillins. We have also the cephalosporins that we will talk about also very soon, and other drugs also, other antibiotics. But that would be the mechanism that those beta-lactam antibiotics work. They work on the cell wall. They interfere in the synthesis of the peptidoglycan, and by inhibiting the transpeptidase, which is an enzyme that catalyzes the final step of the cell wall biosynthesis. So penicillin, what's good about it is it has no effect on our cells. So it doesn't destroy our cells at all. It just works on the antibiotics, on the bacteria, I'm sorry. It works on the bacteria. So certain bacteria, though, develops what we call an enzyme beta-lactamase, which is an enzyme that can destroy the beta-lactam on the penicillin, and it becomes resistant to penicillin. So certain bacteria will create this resistance to the beta-lactam that penicillin has, and with that, it becomes resistant to penicillin. So penicillin will not be effective. So we have to find some other drugs, which we will talk about as we go on, which ones are, used in place of the penicillins. So if we look at penicillins and indications of penicillins, we know that we have two major gram stain type of bacteria. Either you are stained positively, and or you are gram negative. Now, who can recall what colors usually you stain with gram positive? Does it pick up the violet or saffron when you're gram positive?
Isn't it violet?
Yeah, it's the purple color. So you will be colored purple, or violet. So that would be, and then the gram negative will pick up the saffron, which is the red color. So when you stain bacteria and you look under a microscope, you're going to see a lavender or purple color for the gram positive, and a saffron red color for the gram negative. So mainly penicillins work on gram positive, but certain penicillins also work, just a few works also on gram negative, and we will talk about them in a second. But penicillin specifically, the natural penicillins, these ones here, they in general work on gram positive. Now, here are some of the common bacteria that penicillin works on. Streptococcus is the major type of bacteria that we use the penicillin on. So if you have a strep throat or some type of streptococcus infection, penicillin would be the drug of choice. We use it on Treponema pallidum. Now, treponema, anybody knows what treponema gives you? What disease you get treponema from? Syphilis. So syphilis, actually, you get it through Treponema pallidum. It also works on Clostridium. Okay, Clostridium difficile, for example, C. diff, they have spores in them. And what is a spore, by the way? Anybody knows what a spore is? Like if I say spore-forming bacteria, what would that be?
A spore is a dormant form of the cell that's resistant to heat and other like resistance and can be reactivated to preserve the cell.
Absolutely. Yeah, it's the form where bacteria takes itself into when the environment is not is crazy for it to survive. So it takes its own DNA and it puts it in a spore, and then it just, when the environment is right for it, it just goes back to the vegetation stage. So Clostridium is heat sensitive, it's heat resistant. So so that's why heating some of the food that some of this bacteria you find in, it will not kill the spore forming bacteria. You have to really destroy it. So some of these penicillins are very good against some of the spore-forming bacteria. What about Neisseria? What does Neisseria gives you? What kind of disease, anybody? Like Neisseria gonorrhea, let me tell you that. What would that be? So gonorrhea, right there. So you get Neisseria from getting gonorrhea. And we have listeria also. Listeria gives you what? Anybody knows what listeria gives you? What type of infections? Some of the food poisoning, including you know, like on turkey, you'll find that on there. If you eat turkey and you leave it there in the refrigerator for a long period of time, eventually you'll have listeria. So listeria, you know, can live on turkey even in the refrigerator. But if you keep it for a long period of time, you can end up with listeria. So penicillin, of course, you know, the different forms, it depends on the form. It can come in IV or PO, depending on the type. But G usually comes in as IV. So G usually comes in as IV. Now, because it is more sensitive to hydrochloric acid degeneration in the stomach. So if I give you penicillin G, it doesn't come in PO, because when it gets to the stomach, it reacts with the acid that you have in the stomach and it loses its effect. So it's got to be given IV. Okay. Now penicillin V, okay, which is this one, this is given PO, okay, which is not sensitive to the hydrochloric acid in the stomach. So that's why some of them are given IV, some of them are given PO, depending on the type. Okay. So here are some indications. Oral infections, like strep throat, tonsillitis, rheumatic fever, you know, could be caused by streptococcus, right? Severe pneumonia could be caused by streptococcus, arthritis, sepsis, septic arthritis. So septic arthritis is one, and rheumatic fever is caused by strep sometimes. So, so that could be also treated by penicillin. Syphilis, we said, gonorrhea, actinomycosis. Okay, actinomycosis is usually a fungal infection, but it was found that penicillin kind of reduces the amount of fungal growth. It doesn't kill it at all, but it helps it out, because when after fungus, you know, after you have a fungal infection, you can end up having a streptococcus infection after that. Anthrax, we know anthrax is spore forming also, so it's good. Penicillin, you know, penicillin G could be good for that. Clostridium infections, like we said, is penicillin. We can use it. Endocarditis caused by Streptococcus viridin. So Streptococcus viridin is one type of Streptococcus, So penicillin could be very effective. Usually smaller doses are administered intramuscular. So penicillin is given IM, and if it's given injectable. So here are some of the side effects of penicillins in general, the natural penicillins. We have allergic reactions. That's the number one thing that you need to be careful. You always ask your patient, are you allergic to any medications at all? And when you hear penicillin, you want to put down big letters, allergic to penicillin, because it could be fatal. You can die from a penicillin allergy. So usually you start with hives and itching and rash and all that. Then you can start puffing up, swelling. Then it can hit your respiratory and you stop breathing. And then of course it gives you a heart attack. So all that could happen because of the allergies to penicillin. Now you could come out of it and just get the rash and all that, and then get to the hospital, and then they can reverse it to you by giving you Benadryl and all that stuff. You can come out of it, but certain people cannot come out of this. So you need to be careful when you administer penicillin. There are a bunch of people that are allergic to penicillin. Okay, so for us to, if we don't want to use penicillin, we can use other drugs that we will cover. But be careful with cephalosporins also, because if you're allergic to penicillin, you could be allergic to cephalosporin also, because it's a beta-lactam also. It has a beta-lactam in it. So be careful with it. Usually we don't give them any cephalosporin. If you're allergic to penicillin, we put an X on cephalosporins also. So contraindicated with probenecid, which is an anti-gout medication. Warfarin, it also prolonged the action of warfarin, so you need to be careful, otherwise you'll be bleeding more. All antibiotics is contraindicated with contraceptive pills. So if you're pregnant and if you're not pregnant and you're taking birth control pills, penicillins could slow down the effect of contraceptives, and a woman could get pregnant because of that. So it decreases the level of estrogen usually. Antacids also may interfere in the antibiotic, like we mentioned, like penicillin V does not, but penicillin G does. Penicillin G does not, so penicillin V is okay. So antacids, you want to make sure that you don't take both together. All right, let me show you a little video on the beta-lactam and how it works in general. So let's see what we got here.
Antibiotics are medications used to fight bacterial infections. Originally, the term antibiotics referred to natural compounds produced by certain microorganisms for the purpose of fending off others.
Are we supposed to be seeing this video?
For example,
Dr. J, we can't
penicillin
see
is
it.
produced by the fungus. Nowadays, this term
okay.
includes
Sorry about
all
that.
antibacterial products.
I need to share.
Of which are semi-synthetic. Antibiotics are medications used to fight bacterial infections. Originally, the term antibiotics referred to natural compounds produced by certain microorganisms for the purpose of fending off others. For example, penicillin is produced by the fungus Penicillium. Nowadays, this term includes all antibacterial products, most of which are semi-synthetic, meaning they are modifications of natural products. Antibiotics are just one type of antimicrobials. They target bacteria and are usually not effective against other types of organisms. Antibiotics cannot treat viral infections, such as common cold or flu. Antibiotics can be bactericidal, meaning they destroy bacterial cells, or bacteriostatic, meaning they inhibit bacterial growth. Some antibiotics are broad spectrum. They are effective against a wide range of bacteria, including both gram-positive and gram-negative, while others are narrow spectrum. They are more specific, affecting a smaller group of bacteria. Antibiotics can be classified by their mechanisms of action. Inhibitors of cell wall synthesis. Bacterial cells are surrounded by cell walls made of peptidoglycan. Antibiotics that affect bacterial cell wall act at different stages of peptidoglycan synthesis and cell wall assembly. Because mammalian cells do not have cell walls, this class of antibiotics is highly selective. They target bacteria and have minimal effects on mammalian host cells. Disruptors of cell membrane. Some antibiotics disrupt the integrity of cell membrane by binding to membrane phospholipids. Because cell membrane is also found in mammalian cells, these antibiotics are also toxic to host cells if administered systemically. Their clinical use is therefore limited to topical applications. Inhibitors of protein synthesis. Antibiotics that interfere with bacterial protein synthesis may act at different steps of this process, including formation of the 30S initiation complex, assembly of the 50S ribosome subunit, formation of the 70S ribosome from the 30S and 50S complexes, and elongation process. Some of these antibiotics also inhibit the eukaryotic mammalian counterparts, but their effect on bacterial ribosomes is significantly greater. Inhibitors of nucleic acid synthesis. Some antibiotics interfere with DNA synthesis by binding to bacterial topoisomerase II, the enzyme that relaxes the supercoiled DNA before its replication. Some others interfere with RNA synthesis by inhibiting RNA polymerase. Some antibiotics of this class are selective. They do not interact with mammalian counterparts of these enzymes, while others do affect mammalian host cells. The latter are used for cancer treatment instead. Because cancer cells grow faster than normal cells, they are more affected by the action of these agents. Inhibitors of folic acid synthesis. Bacteria synthesize their own folic acid, unlike humans who get the vitamin from food. Because of this, antibiotics that inhibit enzymes involved in folic acid synthesis only harm bacterial cells and not human cells.
Okay. Let me share another video for you, with you.
Structurally, most bacteria consist of a cell membrane surrounded by a cell wall, and for some bacteria, an additional outer layer. Internal to the cell membrane is the cytoplasm, which contains ribosomes, a nuclear region, and in some cases, granules and/or vesicles. Depending on the bacterial species, a number of different external structures may be found, such as a capsule, flagella, and pili. In gram-negative bacteria, the gap between the cell membrane and the cell wall is known as the periplasmic space. Most gram-positive bacteria do not possess a periplasmic space, but have only periplasm, where metabolic digestion occurs and new cell peptidoglycan is attached. Peptidoglycan, the most important component of the cell wall, is a polymer made of N-acetylmuramic acid, alternating with N-acetylglucosamine, which are cross-linked by chains of 4 amino acids. The function of the bacterial cell wall is to maintain the characteristic shape of the organism and to prevent the bacterium from bursting when fluid flows into the organism by osmosis. synthesis of the peptidoglycan, and ultimately the bacterial cell wall occurs in a number of stages. One of the first stages is the addition of 5 amino acids to N-acetylmuramic acid. Next, N-acetylglucosamine is added to the N-acetylmuramic acid to form a precursor of peptidoglycan. This peptidoglycan precursor is then transported across the cell membrane to a cell wall acceptor in the periplasm. Once in the periplasm, the peptidoglycan precursors bind to cell wall acceptors and undergo extensive cross-linking. 2 major enzymes are involved in cross-linking: transpeptidase and D-alanine carboxypeptidase. These enzymes are also known as penicillin-binding proteins because of their ability to bind to penicillins and cephalosporins. Eventually, several layers of peptidoglycan are formed, all of which are cross-linked to create the cell wall. Gram-positive bacteria may have more layers than gram-negative bacteria and thus have a much thicker cell wall. Beta-lactam antibiotics include all penicillins and cephalosporins that contain a chemical structure called a beta-lactam ring. This structure is capable of binding to the enzymes that cross-link peptidoglycans. Beta-lactams interfere with cross-linking by binding to transpeptidase and D-alanine carboxypeptidase enzymes, thus preventing bacterial cell wall synthesis. By inhibiting cell wall synthesis, the bacterial cell is damaged. Gram-positive bacteria have a high internal osmotic pressure. Without a normal rigid cell wall, these cells burst when subjected to the low osmotic pressure of their surrounding environment. As well, the antibiotic penicillin binding protein complex stimulates the release of autolysins that are capable of digesting the existing cell wall. Beta-lactam antibiotics are therefore considered bactericidal agents. Bacterial resistance to beta-lactam antibiotics may be acquired by several routes. One of the most important mechanisms is through a process known as transformation. During transformation, chromosomal genes are transferred from one bacterium to another. When a bacterium containing a resistance gene dies, naked DNA is released into the surrounding environment. If a bacterium of sufficient similarity to the dead one is in the vicinity, it will be able to uptake the naked DNA containing the resistance gene. Once inside the bacterium, the resistance gene may be transferred from the naked DNA to the chromosome of the host bacteria by a process known as homologous transformation. Over time, the bacterium may acquire enough of these resistance genes to result in a remodeling of the segment of the host DNA. If this remodeled DNA segment codes for cross-linking enzymes, i.e. penicillin-binding proteins, the result is the production of altered penicillin-binding proteins. These altered penicillin-binding proteins can still cross-link the peptidoglycan layers of the cell wall, but have a reduced affinity for beta-lactam antibiotics, thus rendering the bacterium resistant to the effects of penicillin and other beta-lactam agents. This transfer process has resulted in penicillin-resistant S. pneumoniae through the acquisition of genes from other naturally occurring penicillin-resistant Streptococcus species. A second important mechanism by which bacteria become resistant to beta-lactam antibiotics is by the production of enzymes capable of inactivating or modifying the drug before it has a chance to exert its effect on the bacteria. Depending on the bacterial species, the gene coding for these enzymes may be found as part of the host DNA or on plasmids, which are small, self-replicating units of genetic material. Bacteria are capable of passing these resistance plasmids to each other by conjugation. When two bacteria come into close contact with each other, a small channel is created between them, which allows one of the bacteria to pass a copy of the resistance plasmid to the other. If the plasmid is transcribed and translated, the bacteria will begin to produce inactivating enzymes. These enzymes, capable of destroying beta-lactam antibiotics, are known as beta-lactamases. In gram-positive bacteria, the beta-lactamase enzyme is generally inducible, resulting in a large amount of enzyme being produced in the presence of the drug. In gram-negative bacteria, the beta-lactam enzymes are produced constitutively, i.e., even when the antibiotic is not present. Gram-positive bacteria release the beta-lactamase enzyme from the cell into the extracellular environment, where it inactivates the drug before it enters the bacterial cell. In contrast, gram-negative bacteria retain the beta-lactamase enzyme within the periplasmic space, resulting in a more efficient mechanism than gram-positive bacteria. Ultimately, the destruction of the beta-lactam ring of the antibiotic renders it incapable of binding to the penicillin-binding protein. And thus, the bacteria become resistant to that drug or class of drugs.
Okay, so hopefully that gave you a nice idea about the mechanisms of the penicillins and how the beta-lactam works. With penicillins having the beta-lactam, with that's how they attack the gram-positive, and where gram-negative bacteria it creates enzymes that can either changes the site of the receptors where the beta-lactam joins, or it creates an enzyme that destroys the beta-lactam. So you know, in order to use penicillin, you have to use it on gram-positive, which do not form the resistance to the beta-lactam. So going further into, so we did the natural penicillins here. So we have penicillin G, benzathine, penicillin G again, you know, it could be PO with potassium, and then procaine also. So so these are, they're just different forms of penicillin in general. Going into the synthetic ones now, these are the ones that we can make in the lab. And again, going back here, penicillins are bactericidal. And from the video, you know that bactericidal is actually killing the bacteria, okay? And so you know, penicillins and the synthetic penicillins, they kill the bacteria, where we have the bacteriostatic, which we will cover, you know, we'll look at some of the bacteriostatic type of antibiotics that stops the multiplication of the bacteria more often than killing it. So, so these are here are synthetic, which we create them to be broad spectrum. Now, broad spectrum, that means they can work on a variety of gram-positive and some gram-negative. So amoxicillin, so anytime you have an amino penicillin, you have an you know, an am next to it in general. But methicillin and carbonicillin also have an amino group in there. So even though the word doesn't say amino, but they have an amino group. And when we talk about amino group in organic, that means we have a nitrogen attached to the structure. So we have nitrogens attached to these structures there, which are an amino penicillin type. Amoxicillin is used a lot for streptococcus, okay, strep throat. They give it rather than penicillin, because just needs to cover some of the common gram-negative bacteria that can live in your throat. But in general, it works. 80% of it works perfectly on gram-positive, and it works on so most likely, if you go and you get a strep throat, the doctor will order probably amoxicillin. So amoxicillin is the famous drug that is ordered for any type of upper respiratory type of infections, if you have them. Ampicillin, also methicillin, and carbancillin. Methicillin is an older drug. You know, we don't use it much anymore, but it was one of the primary drugs that came out to be formed. It was used for MRSA, basically. Now vancomycin is used more, but it used to be used to treat MRSA. So carbancillin beta, you know, it works a little bit more against gram-negative, so that's why it is used. You know, it is used sometimes against gram-negative bacteria. So, you know, that's where you can use it for. Okay. So ampicillin is very broad spectrum type of penicillin that you can use. And sometimes we can add another drug along with amoxicillin, for example, to create what we call augmentin. Probably many of you heard of augmentin. And usually that would, you know, so the galvanic acid will inhibit the beta-lactamase enzymes on the bacteria. So the bacteria, if you remember from the video, they produce this beta-lactamase enzyme, which breaks down the lactam ring. So in this case, the we add galvanic acid to the amoxicillin where it can work on both. So augmentin is very much used in the treatment of upper respiratory that can actually covers gram-negative also. So with ampicillin, I mean, with if you look at some of the side indications for these aminopenicillins, upper respiratory UTIs, urinary tract infection, respiratory tract infections, meningitis, salmonella, and otitis media. So augmentin is used for otitis media a lot, you know. So salmonella, you guys know what salmonella is, right? What is salmonella again? What type of infection when you get salmonella?
Isn't it from food?
Isn't it like digestive
Anyone?
infection?
Yeah, right. So it lives in poultry, right? Or usually food poisoning. So salmonella, food poisoning. So food poisoning in general. Okay. And meningitis, inflammation of the meninges. So, you know, these drugs are good for that, especially ampicillin. Ampicillin is used a lot for these type of, okay, and carbancillin also. You know, all these are used. Let's look at some of the side effects for these guys here. They're broad spectrum. Antibiotic can cause superinfection. So this is important to you guys. Superinfection. What is a superinfection? Who wants to tell me what a superinfection is?
Is it an infection that they're resistant to antibiotics? It's like MRSA?
Yes, but in general, they're talking about sepsis. You know, they're talking about bacteria going all over the body. You know, because like you said, they'll have a little resistance. You know, and when they do that, then eventually they evolve into, or they promote other bacteria that causes sepsis to come in, and eventually the patients will have, you know, like more than one type of bacteria. So superinfections are multiple type of bacteria that comes in and attack. Now, this is one thing that we have to be careful with when we administer these broad spectrums, because we can actually have superinfections coming out of them. It is not common, it's very rare, when you get that, but you need to be careful with that. All right, nausea, vomiting, and diarrhea all the time. Most of these antibiotics in general, they cause this. Specifically diarrhea, you need to be careful with taking too much antibiotics, because you're gonna end up having diarrhea due to a buildup in some of the superinfection. Like C. diff. C. diff is usually a normal flora in your intestine, but antibiotics can destroy the normal flora and make actually the C. diff active. And when it becomes active, then it causes you to have diarrhea. So, so it can also lead to swollen, black or hairy tongue. Certain antibiotics can lead to that, but not all of them. Carbapenem probably causes this if you keep the patient on it for a long period of time.
Dr. J, I had a
So
quick question.
ampicillin, yes?
Oh, sorry.
Yeah.
What do you mean by both when you write both swollen, black, and hairy tongue? Do you mean like both broad spectrum and narrow spectrum, or what are you describing there?
Yeah. So if you, I think what I'm asking, broad spectrum and not the narrow spectrum more often. I believe, I don't know why I wrote both here. Let me think about this a little bit. I'll get back to you. I wrote both. I can't, because you don't find this in narrow spectrum. Maybe they both, maybe I'm talking about two of the antibiotics in this case here. So I know carbapenem does that. Methicillin, probably that's what I meant to say. Carbapenem and methicillin can get to this. Not ampicillin or amoxicillin, but methicillin and carbapenem. Probably that's what I meant by that, and it should be. So I'm going to put down meth and carb.
Okay.
Yeah, that's what I was going with that, but both antibiotics. I know ampicillin and amoxicillin does not cause this, but these right there, these are the ones that can, in long treatment, if you put these people on this for a long period of time, then that's why methicillin is not used anymore, because of this thing. I can remember. Yeah, I remember that now. So
Okay.
we don't use methicillin anymore because of the side effects, that stuff that it causes. And carbapenem also, can lead to that. So.
Okay, sounds good. Thank you.
You're welcome. So ampicillin here, it can lead to acute inflammatory skin eruption. Okay, so erythema. Sometimes you get like a little red spots on your skin, because of that, which is an allergic reaction. So erythema multiforme, which is a red color type of rash that you get on the skin. Redness and peeling of the skin. So you get exfoliative dermatitis. So these are allergic reactions, so allergies. Some people that are allergic to that get this. All right, let's go into now penicillinase resistant antibiotics. So as you remember, we said penicillinase is an enzyme that actually helps form the beta-lactamase. So let's look at this here. So so penicillinase here. So certain people develop beta-lactamase penicillinase, which destroys the beta. So this This enzyme is inside the bacteria. So the bacteria produces penicillinase that destroys the beta-lactam of the penicillin. So in this case, how can we, so the best drugs, so we said Staphylococcus bacteria are penicillin resistant. So these are the ones that you need to remember as penicillin resistant. So the best antibiotics for that would be nafcillin and oxacillin. So nafcillin is the drug of choice for Staph aureus. And Staph aureus is found mainly on the skin, you guys. So when it comes to MRSA, well, MRSA has to do with methicillin. If you remember, that's what MRSA, methicillin resistance bacteria. So in this case, so nafcillin is for staph. So staph is on the skin, it lives on your skin. And many of the skin infections that you can get, Staphylococcus would be the best choice. So, so MRSA, complicated by other bacterium. So you have other bacteria eventually leading to MRSA. And then so this is good. But we'll find out the first drug of choice for MRSA is vancomycin, which is coming up soon. But nafcillin is fine. You can use nafcillin. First line treatment of choice, Staphylococcus endocarditis. So Staphylococcus endocarditis, heart, the inner lining of the heart, staph infection. And also this patients without artificial heart valves. So sometimes if you put an artificial heart valve in a patient, you end up having more of strep and staph infections on them. But if you end up having staph endocarditis without the valve, this is a good choice for you to use. So the drug of choice for Staphylococcus aureus would be nafcillin and oxacillin. So what are the side effects? Pseudomonas colitis. Okay, so pseudomembranous colitis. So pseudomembranous colitis is what you can get from nafcillin administration if you administer that over a longer period of time. So anybody knows what pseudomembranous colitis is? What does pseudo means?
Okay. False.
Yeah, pseudomembranous colitis. So it's a false type of colitis that is you end up having an inflammation of the colon, and you end up having these signs and symptoms to it. So I would remember, like nafcillin, pseudomembranous colitis is one of the side effects that you can get from that. You can have severe or prolonged GI problems, nausea. So again, it's a GI issue that you can get from nafcillin or oxacillin. Sometimes they'll show blood in the urine. Okay. So blood in urine could be one of the side effects. Severe tingling or numbness of the digits, your fingers. You can have blisters also, or ulcers in the mouth. And then red or swollen gums and trouble swallowing. So nafcillin can give you some side effects that you don't like. So that's why nafcillin for Staph aureus, and Staph aureus, again, it's mainly a skin infection type more than anything else. So okay, so here again, let's go back to this here. Primary choice of treatment, treating MRSA infection complicated by bacteria. So complicated by bacteria, that means due to other bacteria, you end up having MRSA. Okay. And that's when you use nafcillin. Anybody knows what are the major causes of MRSA in hospitals? Anyone been exposed to MRSA? Not themselves, but like worked with MRSA patients? Go ahead.
They mostly have had it in their wounds when I've treated MRSA patients.
Say that again, Betsy.
Most MRSA patients have had it in their wounds, like
Right.
their like pressure ulcers or stuff like that. They'll have MRSA.
Mm-hmm. So like gangrenes and stuff like that in diabetics, is that what you're going? Or bed sores in general?
More like bed sores in general.
Yeah. So yeah, because right away, MRSA is attracted. It becomes active, which is a staphylococcus becomes active when the immune system is down. So these sore, again, staphylococcus lives on your skin normally, but it's not very active. It's a normal flora, but it becomes active if you give it a chance, and then you end up having MRSA on your skin because of that. So good. Okay, so now other broad spectrum penicillins would be anti-pseudomonal penicillins. Okay, so these are the ones that are for Pseudomonas and others also, not only Pseudomonas, but they classify them as Pseudomonas because they're very good for Pseudomonas. Okay, so gram negative, Pseudomonas gram negative, if you remember. So gram negative here. So the gram negative. Yeah, so ticarcillin, calvinate, okay, piperacillin, tazobactam. So these are beta lactamase inhibitors also. So these, when we add these, okay, so this one and this one, okay, they're beta lactamase inhibitors. So adding to ticarcillin, which is a penicillin, if we add galvanate to it, add tazobactam to piperacillin, they become beta lactamase inhibitors, so they can attack the gram-negative bacteria in this case. That's why. So a lot of these gram-negative bacteria could be attacked. So used for first-line empiric treatment. Okay, what would be empiric again? Anyone remember from last quarter what empiric treatment would be? Anyone?
Is it just observation or?
Yeah, remember when we said, you walk in, a patient walks in, we put them on empiric treatment first, which is the best guess, right? Your best guess. So until the culture comes back. So that would be the doctor's best guess of the infection. So if you come in with any type of certain skin infection, gynecological, and so on, or urinary tract or so, if you suspect Pseudomonas, right away you put them on this. You see what I'm saying? So this is your best guess treatment, initial treatment, before you get the culture. Okay, so it is used for a wide range of drug resistance susceptible bacteria, septicemia also. So drug resistance, so we put them on penicillin and this, and all of a sudden, these bacteria are very much resistant to penicillin because they're resistant to the beta lactam. That's why we add these into them. We add them in there, and these are referred to as anti-Pseudomonas, like mainly for gram-negative bacteria. That's what we use them for. So Klebsiella species, E. coli, Staph aureus, Pseudomonas, respiratory or urinary tract, because Pseudomonas, you can find it in the respiratory tract and the urinary tract. And then skin and soft tissue gynecological type of infections. Could be also intra-abdominal. You know, you need to suspect the gram-negative bacteria and these antibiotics there for it. So these are anti-Pseudomonas, they call them, or, you know. All right, good. So these are the penicillins, you guys. These are the main penicillins that we have, that we use in general. Excuse me. And so now the, any questions about penicillins before we move to cephalosporins, which are the next category that's very important. So cephalosporins are, again, they have similar structure as penicillin, where you have the lactam rangosome, which is the garage over here, and but the functional group or substituents, we call them, that attaches to the ring are different than penicillin. So this is the structure of cephalosporin, which is similar to the structure of penicillin, which is this one here. Okay. Now, so this, in this case, we have these cephalosporins that are divided into different generations. So cephalosporins are divided into first generation, second, third, and then fourth generation also. So these cephalosporins are synthetic in general, and they are bacteriostatic also, like penicillins. So they destroy the cell wall, like penicillin. They work on a penicillin. And because of the similar structure that they have with penicillin, if you're allergic to penicillin, usually you're allergic to cephalosporins also. So we keep you away from cephalosporins. So again, it attacks the cell wall. And the most common ones, the first generation they work on. So the classification are divided according to what they work on. If they work on gram-positive, gram-positive, gram-positive and gram-negative, and then here more of a gram-negative type of bacteria. So as we increase in numbers of generation, eventually the fourth generation works on gram-negative bacteria more than gram-positive. That's how we classify them. So first generation, they work on gram-positive more than anything else. So you can use these drugs as instead of the penicillins. Many physicians, they like cephalosporins because they're afraid, they have a lesser side effects usually than penicillins. So they put you on cephalosporins. Again, the allergies that you get, penicillin allergy, you get it more with penicillins than cephalosporins. So to them, it's a safer drug to place people on gram-positive bacteria than others. And also, they can work, gram-positive cephalosporins can work on staph also, not like penicillins. Penicillins don't work on staph aureus, where cephalosporins first generation, they work on gram-positive staph and strep. Okay, so it's different penicillin because it works on all staph also, against staph. So that's a positive thing that we use. So first generation would be best for, against strep and staph. So, so Pseudomonas, okay, gram-negative in this case, Klebsiella gram-negative, Enterobacter. So it works on gram-positive in general, but it can work on a little bit of a gram-negative, not too many, not too much, but this is mainly gram-positive type of bacteria. So Streptococcus also, Okay, it gives you oral thrush, like a fungal infection if you use it for a long period of time. So that's one thing that you don't want. You need to be careful with. Oral thrush, fungal infection, vaginal itching or discharge, and usually it's fungal, yeast also, like a yeast infection. So antibiotics in general, okay, can lead to yeast infection. Why is that? Anyone can guess why antibiotics can lead to that?
It gets rid of all flora, even the good flora.
Okay, so you destroy the normal flora. You can destroy some of the normal flora. And when you do that, what happens? What's the fungal infection relation to destroying the normal flora?
There's an overgrowth because of it.
Okay. It has something to do with your system. Which system is it? So when bacteria, when fungus grow, usually it attacks what kind of patient? Risk patient.
Immunosuppressed.
Immunosuppressed, exactly. So fungus comes to immunosuppressed patients. So like HIV, in fact, any type of immune suppressant type of disease, always suspect fungus or yeast to grow on these patients. So with antibiotic, you're using antibiotic, you're destroying the normal flora that puts you into a susceptibility of being at risk of being immune compromised. And with that, you're going to end up having thrush, which is fungus, and or yeast.
I have a question really quick.
All right, so yeah.
I was just wondering, can't you take like probiotics to help with the fungal infections or like yeast infections? When you're on an antibiotic or no?
No, probiotic is just promoting your normal flora. Okay, that's what it is for. So it boosts your immune system by promoting the growth of the normal flora that you have. So can you take it after you get this? Is that what you're saying? Is that what you're asking, Gabby?
Yeah.
Yeah. If you have this issue, okay, specifically GI more than anything else, probiotic could be a good choice. Yes.
A lot of times doctors will tell you to take a probiotic or to take to eat yogurt to help to like prevent a yeast infection too.
Yeah.
To prevent what?
Like if you're on an antibiotic, if your doctor puts you on an antibiotic, they'll say as a preventative measure, they'll tell you to take a probiotic or eat yogurt to help prevent a yeast infection for females.
Yeah. So what is the reason? Go ahead and analyze this. Why is that? So probiotic is what? It promotes what?
Your normal gut flora.
So if you promote your normal flora, that's going to reduce the chance of you getting what?
A fungal infection.
Yeah. So that's the logic behind it. So you're going to get less chance of getting fungal infection because of that probiotic. That's a great point. Excellent. All right. So that's first generation. So Keflex, okay, cephaloxime is the drug of the #1 choice of doctors. They use this a lot, Keflex, So if you talk about cephalosporins, you're going to find out that the term ceph is always there. CEPH or CEF. And then we have chlor later on, so you can notice a lot of cephs, involved. So as soon as you see ceph something, ceph, think of it as an antibiotic, as a cephalosporin. So that's easy enough to remember. Cefazolin, Ancef, cefadroxil, which is Duracef, that is used. Cefazolin comes as IV usually. So if you need an IV drug, Keflex usually is a PO. and it comes as PO oral. You know, it's administered orally. Okay. So second generation, as we move up now we're gonna get closer to covering more of gram negative, but again, it's gram positive in general. So middle ear infection. Okay, what's the most causative agent of middle ear infection? What do you guys think? So in the middle ear, what do you have? You have a tube that goes down your from the middle ear.
Eustachian tube?
Eustachian tube. Good job. So that connection that you have to your throat will allow what to go into your ear, middle ear? What's the most common bacteria that lives in your throat? What's the most common bacteria that lives in your throat?
Strep?
Strep, yeah. You get a lot of strep throats, don't you? So streptococcus goes where? Into your middle ear through the eustachian tube. And that's why we use these drugs for it, because of, the strep in general. Now, you can have other bacteria attacking your middle ear besides strep, but this is the most common. If you have tonsillitis or pharyngitis, eventually you can have an ear infection because of that. Middle ear infection, otitis media. So again, pharyngitis, streptococcus, tonsillitis, streptococcus, skin, strep or staph. So because we can have a strep infection and a staph also infection on your skin. So Ceclor, cefaclor is very, very commonly used, the #1 drug used. Respiratory tract infections, you can have a strep pneumonia, you could have a strep pneumonia that can lead to lower, the lung. So again, we have the same thing here with these cephalosporins giving you these type of side effects, same as all of them in general. All right, now we get into the third generation. So we're going to cover some of the gram negatives now. So ceftriaxone or Rucephin is commonly used. It's very commonly used. IV usually. This is IV. Most of these are IVs. Fortaz and. So these are, Duracef is Duracef, Duracef, we covered that before. Omnicef is IV. Most of these guys are IV. So these are IV. So these are, you give them IV to susceptible bacterial infections of the lower respiratory tract, skin infections, bone and joint infections, acute otitis media, UTIs. Now, UTIs, what are the most common bacteria that is found in E. coli, right? And what is the other one also?
VRE.
Pseudomonas. And what's the other one? Somebody said?
I thought VRE, but maybe not.
Yeah, VRE. These are the most common ones that you find in the lower, in the UTIs. So this is like severe UTIs, like when you have the bladder involved and you have other urinary tract infections, okay? Septicemia, so infection all over the body. And pelvic inflammatory disease, PIDs. So what is PID again? Anybody?
Pelvic inflammatory disease.
Yeah, but where do you have, what's inflamed?
Like everything around the lower abdomen.
Pelvic cavity.
In the lower, in the pelvic cavity, yes, the pelvic. So what organs lives in the pelvic cavity?
Reproductive and like urinary.
Mm-hmm. Yes. So you can infect any of these things and then you end up having PID. All right, so that this could be used for it. So intra-abdominal infections, meningitis, uncomplicated gonorrhea, and surgical prophylaxis. Okay, so what does that mean?
It means you're preventing risk of further infection after surgery.
Yeah, before surgery, we give them antibiotics just to prevent them from getting an infection after surgery. So you can put them on some Recephin, before surgery, and just to prevent them from getting any infections. So some of the side effects are injections, side reaction, because you give them sometimes IV or IM. So you get a little pain, swelling, soreness, and all that. And some gives you loss of appetite, a little loss of appetite feeling there. So, all right. So let's go ahead and work on the next, on the fourth generation. So now, So the fourth generation, in this case, we are more of gram-negative. Straightforward. So again, it is used for empiric therapy for febrile neutropenia patient. All right, who wants to tell me what is neutropenia?
A deficiency in the neutrophils.
Yeah. So we discussed that in pathophys, and you can have febrile. What is febrile again?
Fever.
So you're getting fever due to the neutropenic patients, neutropenia. Yeah. So if you suspect neutropenia in patients, and we can get neutropenia in multiple different reasons, specifically leukemia type of patients and all that, then right away this is a good drug to use. And because we are suspecting gram-negative bacteria more than anything else on this. So uncomplicated and complicated urinary tract infections, pyelonephritis, skin infections, complicated intra-abdominal infections. Usually it is used in combination with metronidazole. You know, what is metronidazole?
Is it an antifungal?
Yeah, it is used as an antifungal, antibacterial also. You know, it could be used for more of to prevent the formation of fungus. You know, when you are on antibiotics. So usually we give you metronidazole for that. Specifically, if we suspect abdominal. So some of the side effects would be abdominal or stomach cramps, back, leg, or stomach pain, bleeding, gums, nosebleed, convulsions. So we're getting serious here, right? So some of the side effects here that you don't like, you don't want actually to get. So we try to stay away from a fourth generation unless if we really have to, you know, to use it. But it's still, the side effects here are lesser than other gram-negative type of antibiotics that we will cover later on that can lead to serious side effects. So, so these are still kind of controllable type of side effects. So that covers your cephalosporins in general. And then we go into the carbapenems. The carbapenems are usually fairly new drugs, but they've been in the market for about 20 years. You know, they're very effective. And they are the drug of choice for physicians when it comes to empiric serious type of infections. So if you have sepsis and bacteria that you don't know how to treat, or you don't know why the other antibiotics are not working, right away, imipenem is the first common drug that we use in order to take care of that. So it is a broad spectrum in general that covers a lot of variation of bacteria. It's a bactericidal, so it kills the bacteria also. It has a, again, it has a lactame ring. So, so this lactame ring looks similar to penicillin, so it works similar to that. It inhibits the cell wall again. So it works on the cell wall like similar to the penicillin. So it inactivates the transpeptidase again that forms the blood, cell wall. So microorganisms, staph, Pseudomonas aeruginosa, Enterococcus specimen also. It is very potent, not used frequently, preserve its effectiveness against bacteria, okay? So again, when do we use this? When we are, we don't know what the bacteria is, or the regular, specific drug, specific antibiotic, or narrow spectrum is not working. So we put them on this. It treats serious infections, lower respiratory tract, urinary tract infection, abdominal, gynecological, bone, joint, skin structures, endocarditis, polymicrobes. Okay, so if you have more than one, microbe, septicemia. So think of bacterial septicemia is where we're going with that. So what kind of side effects you would get? Again, nausea, GI stuff, itching, swollen tongue sometimes, pain when a medicine. So nothing serious here. So it's very safe to give. You know, you give it, and it covers lots of. Premaxin is the drug of choice. You know, imipenem. Ertapenem. Again, you have the penem involved in the last name here. So imipenem. Then you're thinking of carbapenem. All right. All right. So we're done now with the beta-lactam. So everything that we covered up to now, they work on the cell wall, and they're beta-lactam. So the next drug classification we'll work on is the fluoroquinolones or quinolones. So fluoroquinolones or quinolones are drugs that usually are used for gram-positive and gram, okay, but they work on the DNA. So they work on the DNA of the bacteria, they're bactericidal. And we said that you have, so, you know, so what do we, from a video, what do you remember about the DNA of the bacteria? What did you understand from the video about the chromosomes and the DNA of the bacteria? Do we, does bacteria have a chromosome in it? Yeah, usually you have a single chromosome that is very, very large, you know, and it's looped around itself. And there you transcribe the DNA, you know, you transcribe proteins using that DNA that you have inside the bacteria. So, so it actually interferes, these quinolones, they interfere in the DNA synthesis. And we said you need folic acid and folate to help, you know, produce the DNA. And in this case, they inhibit the unwinding of the DNA. So the unwinding has to do with gyrase and topoisomerase. So topoisomerase 4 and gyrase are the two enzymes that unwind the chromosome or the DNA in order for it to go into transcription and then eventually translation. So that's where quinolone works. They work on inhibiting the DNA gyrase and topoisomerase 4. And sometimes type 2 topoisomerase also. But in general, they work on isomerase 4, and which is and gyrase, DNA gyrase. All right, and so if they inhibit the synthesis of proteins through blocking the unwinding of DNA, the bacteria is not going to multiply. It's going to die. And ciprofloxacin is a very common drug, Cipro. Leaves, again, we have a floxacin involved in this case, so anytime you see a floxacin, then you know it's a fluoroquinolone or quinolone. So fluoro because you have a fluorine atom there attached to the quinolone. So indications, acute exacerbation of chronic bronchitis. So when you have chronic bronchitis, you can use this. It's very effective. Skin infections, bone and joint infections, acute sinusitis. So this one works again on both gram-positive and gram-negative. So don't forget that. So it works on both. So all these, you can have gram-positive or gram-negative in general on any of these things here. So this is a nice broad spectrum that you can use on both gram-positive and gram-negative. UTI, abdominal infections. Chronic bacterial prostatitis. Okay, so that's where you have a infection of the prostate. And then acute uncomplicated cystitis in females. So this one, so Cipro, if you suspect there's a gram-negative, if it's a gram-positive only, you don't use Cipro, because this one is like, it works on, attacking the DNA synthesis. And if it's only gram-positive, we can hit the cell wall with penicillins type of drugs or beta-lactam type of drugs. But in this case, you need to suspect that there's a gram-negative in order to use the quinolones. Here, there are some side effects here. So we have increase in person risk of tendinitis, tendon rupture, may cause permanent nerves. So this is important to remember. So if you put people on Cipro, some people can have issues with their tendons. So they can have issues with the tendons where they call tendinitis or tendon rupture because of that. So that's one side effect. Serious mood or behavior change. So some people, they go into the mood change after just one dose. Low blood sugar, that's another thing. So you can go into low blood sugar, which can lead to coma. I mean, this is not a common one, but they found out that some people can get this. So it can have a serious side effect on very few people. Moxifloxacin has a slow clearance rate, so should not be used with UTIs. So this is important to remember. So this one here, moxifloxacin, has a very slow clearance rate. That means it does not leave the blood and the urine, it does not leave the blood. So its bioavailability is very, very high. It stays in the blood for a long period of time. All right, so these are what? The quinolones. These are the most common quinolones used. The next one is aminoglycosides. Aminoglycosides are very, very important to remember because they have very, very serious side effects, which are these over here. So we need to be careful when you use them. So you've heard of gentamicin and clindamycin, all the mycins. So all the mycins, amikacin also, and streptomycin. So streptomycin is a drug that is used for serious type of bacterial infections, all right? And we need to remember that it works on the protein synthesis, the 30 subunits, 30S subunit of the ribosome that causes protein synthesis. So, so streptomycin works on the ribosomes, amikacin, neomycin, clindamycin, and gentamicin. So gram-negative bacteria in general, so Pseudomonas, Proteus, E. coli, Klebsiella, pneumonia, Enterobacter, aeruginosa, or aerugine, and Seriata. Also Staphylococcus. So Staphylococcus is gram-positive, but it works on some of the gram-positive, also like Strep. So indications: serious bacterial infections, chest infection, UTI infections that are very serious, infected wounds or burns, cystic fibrosis, all right? Cystic fibrosis, let me put this up here. This is very important to know. Streptomycin is used for also serious infections like the plaque. Okay, anybody knows what the plaque is? I put it somewhere else here. But anybody else? Anybody heard of a plaque? Have you heard of, it's a very, very contagious disease that came from, it was transmitted through rats.
Are you trying to say the plague?
Yeah, the plague. The plague from plague, sorry. So the plague, which is caused by Yersinia pestis, which is a bacteria that led to a lot of, it's very contagious, and you know, people die from it. Try and watch the movie. I don't know, there's a movie or a documentary about Yersinia pestis and the plague that we had that came in way back. I think it was it came in about 30 years ago or so to the U.S., where people got infected by it. So again, so this is basically streptomycin is was the drug of choice for this one here. Also, serious infections like cystic fibrosis, you know, is also used. So cystic fibrosis, infections due to cystic fibrosis. That's where we're going with that. Infections with cystic fibrosis. So cystic fibrosis, we know that's blocking the ducts, and but you can get infected after that, and you know, these aminoglycosides are good for this. So let's look at the side effects here. So why don't we use gentamicin or aminoglycosides a lot? Because it can use ototoxicity. So you can lose your hearing, you know, when you go on aminoglycoside for a while. You have a roaring sound in your ears. Nephrotoxicity, which is basically kidneys, failure of the kidney. You can have severe ongoing dizziness, weak or shallow breathing, numbness, tingling feeling, neuro. So neurotoxicity. So neurotoxicity would be also with that, and that's where you get your you will get numbness or tingling feeling. Twitching of the muscles, tingling, contraction, seizures. So these things can cause, gentamicin can get to that. It can lead to neuromuscular blockade, so people that have myasthenia gravis, if you remember, has something to do with smooth muscles, paralysis of the smooth muscles because you have reduced acetylcholine. So, so clindamycin can lead to Pseudomonas colitis, which is severe. It gives you diarrhea and all that stuff. Pseudomembranous, I'm sorry. Pseudomembranous colitis, the one that we just discussed earlier. And then poor lung penetration. All right, so that's why aminoglycoside is not used much, but they're still used, but because of all these side effects here, they're not used much. All right, so we said this one works basically on 30S. Now, sulfonamides are the different ones. And again, they work on this one. They inhibit the synthesis of the DNA by blocking the synthesis the enzyme that makes folic acid. We said, like in the video, bacteria makes its own folic acid. So sulfonamide kind of blocks the enzyme that causes the bacteria to make folic acid. So with this case, it interacts, interferes in the PAPA formation. Okay, and we said this is just basically creating, it inhibits the dihydrofolate reductase, which makes eventually your folic acid. So it inhibits the folic acid synthesis, which you need to produce nucleic acids of the DNA. So, so in order for you to create the DNA, you need folic acid. And this sulfonamide will interfere in inhibiting the dihydrofolate reductase that eventually makes folic acid in the bacteria. All right, so the next thing is, so indications for this, pneumonia, bronchitis, UTI, ear infection, intestinal, traveler's diarrhea, you want to remember that one. So traveler's diarrhea is, this is what we, so if you go on a trip and we worry about you getting infected by some kind of bacteria there by drinking the water or anything like that, then we put you on prophylaxis of sulfonamide. The country Metaxazole, okay, Maxazole, country Maxazole, Bactrim, okay, that's the generic trade name, is very, very commonly used. And usually it is, it's added, you add sulfamethoxazole to it to make it Bactrim. So it usually comes as a combination. So Bactrim, is a combination of sulfamethoxazole and trimethoprim together. All right. So when you put people on Bactrim, you put them on it if you are if they're going on a trip and you want to prevent them from getting any type of bacterial infection, because it is a broad spectrum. Now this one is a bacteriostatic. Okay, remember that. So what is bacteriostatic again? What does it do to the bacteria?
Inhibits it from growing, like continuing.
Yeah.
To
so it doesn't actually kill it. More often than it just interferes in its production of, eventually it dies, right? But but it stops the, it doesn't destroy it, rather than it blocks its synthesis, you know, that synthesis of the proteins inside, or synthesis of the folic acid in this case. So if you interfere in its function, it's referred to as bacteriostasis. If you kill it, then it's referred to as bactericidal. So, so certain ones they kill, certain other ones they just interfere. So, so this one are the sulfonamides, the sulfa drugs we call them. So Bactrim is very, very commonly used. Again, you know, it is used for UTIs, intestinal. What are some of the side effects? GI discomfort, severe diarrhea. Sometimes you end up having watery stool, stomach cramps, and then you know, things like that. All right, you guys give me 1 minute. I'll be right back. Okay, hang in there. I'll be right back. Did you pick up anything from front? Did you hear? We heard that. All right, sorry about that, you guys. All right, so the next drug we'll talk about is tetracycline. So tetracycline would be the next classification. And when we have cycline in the name, then automatically it's a tetracycline. And this one inhibits the binding of amino acid transfer RNA. So this has a lot to do with the protein synthesis in this case. So if you remember, tRNA is the type of RNA that brings in the amino acid into the messenger RNA eventually to translate it into protein through the 30S. So here we got the 30S, which is the cap of the ribosome. The 50S sits in the bottom, the 30S sits on the top, and then you have the messenger RNA going through it in between them. So this is where it inhibits the binding of the amino acid tRNA to the messenger RNA. So when this does not bind anymore, then you don't form proteins. So this is tetra. Why is it called tetracycline? Because it has 4 cycles. If you see that, you have 4 cycles next to each other, 4 cyclic structures. That's why it's called tetracycline. So it also binds to calcium here, it says. So that's important to remember. All right, so indications, broadest antimicrobial, so it's very broad spectrum. It is aesthetic, so it interferes in the, so if you notice, you know, like for sulfonamide, they work also on the DNA. It's a bacteriostatic. This one works on the connecting the transfer RNA with the messenger RNA. So it's aesthetic, okay, so it stops the formation of something within the bacterium itself. So it's very broad spectrum. It is used usually for atypical organisms, okay? So, we're talking about chlamydia, mycoplasma. What is mycoplasma, you guys? How is mycoplasma different than the others? is very, very important. When you learned microbiology, what was significant about mycoplasma, bacteria? Anyone remembers? So mycoplasma lacks cell wall. Okay, so mycoplasma does not have a cell wall. It has only a membrane. So that's why you need this. You need to use this because it works on the inside of the tetracycline, not the outside. So so mycoplasma bacteria. This is a good drug. Chlamydia. Okay, so chlamydia is atypical. You don't get chlamydia all the time. So chlamydia infections, is chlamydia sexually transmitted, you guys?
Yes.
Yes. So STD, so this can be used for an STD. So what is rickettsia? Anybody knows what rickettsia is?
Is that what you get from ticks?
Yeah, good job. Ticks. So ticks, you can get that from ticks. And it's good for protozoan parasites. Now, this is the only antibiotic that can be used for protozoa, which is a parasite, isn't it? So this is a parasite, protozoan, which is, you know, like amoebas and all that, right? So amoeba could be one type of protozoa. Acne, this is very commonly used. Many people with acne uses tetracycline. But what is, or doxycycline, what is the problem with tetracyclines though? You know, we don't use them because they have some serious side effects. So some of the most important one I want you to remember is you never use it in children, right? So never use it in children under 9 years old. Why is that? Because it gives them gray teeth, because this one attaches to the calcium. Remember here it says binds to calcium. So let's take this out of there and put that here. So it binds to calcium. So when it binds to calcium, it gives you what? Eventually, discoloration. You know, so it binds to the calcium in your teeth and it gives you discoloration. That is usually a gray teeth in children. So also it can give you that swollen tongue and black or hairy tongue, okay? So that's why we don't use that much. Again, sores or swelling in the rectal or genital area, my God, you know, who wants that, right? So you don't want that. So tetracycline can cause this. White patches, sores inside your mouth. So sores, you know, you get sores by the mouth, you get sores by the rectum, you know, so sores by the rectum, you don't want that. So that's you know, vaginal itching and discharge because of the yeast. Also, we have yeast formation. So, all right, contraindicated pregnant woman, because again, pregnant woman, why? Because we don't want them to get the gray teeth, and babies will be born with that. So avoid its exposure to light. So again, this is important here. So you don't want people with tetracycline be exposed to light because it can cause severe burns on the skin. Never take with dairy product. Must wait 30 minutes after dairy product. So again, it interferes, you know, dairy product interferes with tetracycline, so you should not take it with it. Also, always drink with plenty of water. But this is a serious drug here to take. We don't want to take it unless if we really have to. So choices of taking the best antibiotic it depends on the patient. So let's say that a patient all the other choices that we have does not work, and we have no choice but to place them on tetracycline, that is fine if they're older. If they're older, but be careful with some of the side effects like the sores that you get around the mouth, and you need to be careful. If you get them, you need to heal them. So never take with dairy product because it interferes. Avoid exposure to light. So this is important also. It interferes in its chemical structure also. Light does that. Not only it causes severe burn, but it breaks down the structure here. So you need to, tetracycline sometimes, if it's going to, like to different floors and so on, they cover it with those brown bags also. So most of the drugs that you need to avoid, sunlight or even light in general, you need to cover it with brown bags. The other classification is okay. So macrolids are samples. So would be azithromycin, clarithromycin, okay, which is the drug that everybody wanted to give for COVID. So azithromycin was the Z-Pak. This is the Z-Pak. Okay, you've heard of that before. Again, it works on it interferes with the 50S rather than 30S. So we said the other ones were 30S. So the tetracycline or tetracyclines are 30S, and this one here, which is aminoglycosides. So aminoglycosides and tetracyclines are 30S, where macrolids are the 50S subunit. But again, it's still translation. It inhibits the translation process of proteins. So it's a bacteriostatic. Again, if it works on the ribosomes, usually it's bacteriostatic in general. So it's bacteriostatic. And first choice to individuals with allergies to penicillin. So this is a good choice. If you're allergic to penicillin, its structure does not have a beta-lactam. So automatically it's good to as a choice for, so clarithromycin is very common. Erythromycin, everybody heard of that before. So this is used if you're allergic to penicillin. Sinusitis, acute otitis media, again, if you have a strep or staph type of infection, but in general strep, then this is good for you. If you have urethritis, cervicitis, and a chancroid. What is a chancroid, you guys? Anybody knows what a chancroid is? Anybody knows what a chancroid?
Is it a sexually transmitted disease?
Sexually transmitted, yes. And what kind of lesion is that? What is that? Is that like an ulcer? You get like a coin-shaped ulcer that you get in the genital area. More common in men than women, but you get that. So you get like a coin-shaped type of structure down in the genital area. So so that's one of the things that it could be indicated for. So all these are indications, uncomplicated skin disorders. So straightforward type of skin, like folliculitis or something like that, maybe, that's uncomplicated. So you can have folliculitis, which is inflammation of the follicles of the skin. All right, so side effects of this, mainly GI symptoms. People go to the bathroom a lot, a little diarrhea there. Erythromycin, cholestatic hepatitis. So cholestatic, what do you think that is? Just translate the terminology for me there. So COLI stands for what?
Has to do with the gallbladder.
Yeah, so COLI, when I say cholecystitis and coli gallbladder, so it has something to do with the gallbladder and hepatitis due to gallbladder issue. Okay, static, it means stoppage of usually a blockage somewhere in the gallbladder canal that lead to hepatitis because of that. And it's usually an allergic type of, so you get that from erythromycin. Some people can get that as a side effect. You have elevated BUN, so that's one thing. So, I can ask a question with the patient came in with elevated BUN, created an allergic reaction, liver reaction. Which of the drugs are we dealing with here? So by knowing the side effects, that we're dealing with, any of these macrolides. So you have drug interaction Saldane, which is an antihistamine, and digoxin also. So you don't want to use these with it. The next classification is chloramphenicol. Chloramphenicol is a very, very important drug to remember. The chloramphenicals, which is straightforward, the drug name is chloramphenicol. So this one is bacteriostatic again. So, but it works on the elongation process. So it works on the elongation process of the protein. So if you remember that the elongation process happens end of the protein synthesis when we put the amino acids together. So amino acids sitting next together, eventually it gets elongated, and by inhibiting the peptidyl transferase, that's the one that actually transfers one amino acid to the other to create a peptide. So it prevents the protein chain elongation. So that would be chloramphenicol. So chloramphenicol, it's a bacteriostatic. So if you notice, bacteriostatics, if it has something to do with the ribosomes usually and the protein synthesis, it's usually bacteriostatic. If it attacks the cell wall and block the folic acid or so, then it's bactericidal. But anything that has to do with the ribosomes in general, it's more likely is a bacteriostatic. Now, serious infections, chloramphenicals are used for serious infections that are, we can't use any other antibiotic for it. So some also serious infection is caused by antibiotics. We can't use serious infection that we cannot use any other antibiotic for it. Meningitis, I want you to remember that. Plague also could be used for plague. Cholera, typhoid fever. So what do you notice here? These are very rare type of infections there. So cholera is caused by what? What organisms is cholera caused by? I mean, classification-wise. Is it bacteria, parasite, fungus, what?
Isn't it parasites?
Parasite, yes. And then typhoid also. Typhoid is more of a bacteria. Plague bacteria, meningitis also bacteria. So it can be used for types of organisms that we are unable to use any other antibiotic for it. So it's called superinfection. So serious infections so chloramphenicol. So if I ask you on the test, somebody was diagnosed with cholera or meningitis or typhoid fever, right away think of chloramphenicol as a choice. Now here's a serious side effect, aplastic anemia. So who wants to tell me what aplastic anemia again? Covered that yesterday.
Isn't that just anemia from a deficiency of blood cells?
Yeah. Deficiency in, again?
Like blood cells from the bone marrow in general?
Right, right. So aplastic. So we have, you know, decreased in, you know, so we have actually no production almost, right? Maybe nil production, down nil. No production of what? Of no production of blood cells. So with this, you don't have that much blood cells are coming. So this is serious, isn't it? So it attacks the what? It attacks what? The bone marrow. So it attacks the bone marrow, and by that, you end up having aplastic anemia. All right. Keloids are the other classifications. Again, this is telithromycin is the drug that is commonly used as a keloid. It is, it attacks also, it binds to the 50 subunit, okay? So would that make it bacteriostatic or cytal, you think?
Static?
Yeah. It's more bacteriostatic because it does, works on the ribosomes again. It blocks the progression of the growing polypeptide again, so it works on the ribosomes. Community-acquired pneumonia. You know, I want you to remember that one because this is very commonly used for community-acquired pneumonia. What is community-acquired pneumonia means?
You get a pneumonia from an area that has a significant number of cases.
Yeah, so so it's not hospital acquired, right? Nosocomial. So hospital acquired is nosocomial. Community acquired is within the community outside the hospital. So this is the normal pneumonia that you get being, you know, walking around and being with other people and so on. So again, this is good for that type of pneumonia. Strange taste in the mouth, you know, so you get also that GI symptoms and vaginal itching, vaginal discharge. Again, we're talking about yeast infections in this case. So you get a taste, a strange taste, like metallic taste in the mouth also. All right, so keloids are, you know, they're used, but they're not used much. But for pneumonia, sometimes you put that patient on there. Lincosamides are clindamycin and lindamycin. These are the most commonly used. Again, these are the ones that are bacteriostatic. They work on the 50 subunits. So by inhibiting the translation of messenger RNA. Joint pain, heart pain indications, I would say similar to the you know, like pneumonia and so pneumonia would be the most common type of indications in this case. So clindamycin, lincomycin, you know, it attacks more of a gram-negative kind of gram-negative bacteria. Okay. So mycins in general, when you say mycin, it's a gram-negative type of bacteria. All right. A glycopeptide, lipoglycopeptide. So again, this has to do with the breaking down the peptoglycan layer, okay? And we said the peptoglycan layer that sits in the cell wall. Anyone has a question? Aaron? No? Okay.
No.
Okay. So inhibition of peptidoglycan layer biosynthesis, and also it selectively inhibits the nucleic acid. So it does two things for this one here. So, so this is the cell wall actually. That's what we have. All right, so it does work on the cell wall, and it works on the ribonucleic acids, which is the RNA synthesis. So it can work on both. It inhibits the synthesis of RNA, and it works on the cell wall. So vancomycin. So this is the drug of choice, okay, for MRSA. So underline this and remember this. So this is the first choice that if we suspect MRSA, we put them on vancomycin right away. So serious gram-positive infections include, so like MRSA gram-positive, serious gram-positive, lower respiratory tract such as pneumonia, community pneumonia, nosocomial pneumonia. So all kind of pneumonia, if you notice here, this is good to treat pneumonias because pneumonia could be a serious infection. People can die from pneumonia, of course. So this vancomycin is excellent for it. Treats again, positive and negative, but in general, a lot of positive. The serious positive ones would go with vancomycin dramatically. Enterobacteria, pseudomembranous colitis, again, enterobacteria is the one that, by the way, enterobacteria can lead not only to it could be, it can cause UTIs also, enterobacteria, UTIs. Yeah, and UTIs. All right, so what is the problem with administering vancomycin? Serious allergic reactions, anaphylactoid reaction. This is a very serious reaction usually. So including blood pressure, low blood pressure, wheezing, asthma, shortness of breath. So this is really serious when you get the anaphylactoid type of reaction. Indigestion, hives, itching, rapid infusion vancomycin may cause flushing of the upper body. So all the time, so you need to be careful, monitor how fast is the drip, right? So otherwise, you're going to end up having flushing the upper body, and you're going to end up what we call a red neck. Right? So that could be a nice question on the test. Patient, after administering a certain antibiotic, rapid administration of antibiotic, eventually a patient have created what we call red neck. What would be the antibiotic, vancomycin? So, details, you guys, again, most of the questions on the NCLEX or MIC exams or any of the exams, side effects are very, very essential. If you know the side effects of things, you will be magnificent in therapy, because all cases, they always give you clues. And these are the clues right there, the side effects. Could be a mechanism, could be a side effect. Because the indications, they overlap. If you notice, you can use many antibiotics to treat different types of symptoms, different types of infections. But the side effects are what separates different antibiotics from each other. And that's where you need to remember. If I were you, I would concentrate a lot on the side effects. Make sure you know the side effects of every drug. That's how you excel. When I create questions or I bring in questions from pool or so, I look for these things. I look for side effects that can identify the drug, because I got to give you those clues in order to go and aim at that drug. So we can't just give you which antibiotic is used for respiratory tract infection. My God, all of them could be used, right? But I got to give you something more in order to direct you to vancomycin. Like I said, rapid infusion. So when you do rapid infusion, you're going to have issues with that. So that's why they put that down here. I'm not going to give you hives because many drugs causes hives and itching. Dizziness, same thing, but I would, anaphylactoid reaction is caused by this, wheezing, low blood pressure. This one, it could be used with others. You could be allergic to others to cause this, but I can add this along with the red neck and all that, then automatically you think of the vancomycin. So always know mechanisms and side effects or adverse effects to do very, very well in the on your NCLEX. I mean, I'm bringing a lot of questions for you from there, and a lot of them has to do with the, with those side effects. All right, let's finish up here, and we have two more categories. Yeah, question?
Don't we have to do the trough and peak for Vanco?
I'm sorry, say it again.
Don't we have to do a Vanco trough and peak?
Yeah, absolutely. Tell them about it.
And for gentamicin too, right?
Gentamicin also, because of neurotoxicity and all that. Absolutely. Yes. And why do you think you do that on vancomycin?
You adjust the dosage. Mm-hmm. So the trough is before the next, before the administration of, before you hang the medication, and the peak I think is like 1 to 2 hours after. And then depending on that, you'll adjust the dosage of the next dose. Absolutely.
So in order to avoid this rapid type of infusion in there, because we don't want that. Excellent. It's nice to have you, Betsy. You're bringing a lot of experience from what you do. All right, so going into the next one, which is antimycobacteria. Okay, again, we said mycobacteria are the ones that don't have cell walls. So here are some of the TB drugs, we call them. So because tuberculosis, Mycobacterium tuberculosis, is the bacteria that causes TB. And these drugs are used for that. So here are some of the drugs: isoniazid, rifampin, and pyrazinamide, ethambutol, and streptomycin. So these are the main combo that we use to treat you if you have TB, tuberculosis. So this is a regimen we call the red give you in order to treat you if you are positive for TB. So INH, it inhibits the formation of mycobacterial cell membrane, okay? Okay, I'm sorry about that. I told you this is it. No, mycobacterial have cell walls. Mycoplasma does not, okay? So sorry about that, made a mistake. So mycobacterium, okay, they do have cell walls. Mycoplasma do not have the cell wall. I can use it myself, okay. So these bacteria have cell walls, and so INH inhibits the formation of mycobacterial cell wall, okay. Rifampin inhibits the bacterial RNA polymerase. So what did we say RNA polymerase does?
Isn't that a part of the transcription?
Yeah, so here we go, right there. So the enzyme that's responsible for transcription. So when we transcribe the DNA onto messenger RNA, we need RNA polymerase. So rifampin, R for R, remember that. So rifampin is for the RNA polymerase, all right? So INH works on the cell wall. Rifampin works on the RNA polymerase. Pyrazinamide diffuses into the granuloma, okay? So what is a granuloma here? What's a granuloma? What did you say granuloma in pathophys?
Does it have to do with the myeloid progenitor cell?
Okay, so granuloma is a lesion, right? It's a lesion that you find where? Inside your lung. So this lesion inside your lung, that's where you have actually the Mycobacterium tuberculosis sitting in there. So if we take a sample of the lung, if we look at it, we're going to see like coin-shaped lesions that are granuloma. that has a lot of calcium in it, and that's where actually this mycobacterium live in. So so this one here, pyrazinamide, it goes into the granuloma, where the TB enzyme pyrazinamidase converts pyrazinamide to the active pyrozonic acid. So going from one to the other, that's where pyrazinamide works. So it works inside the granuloma in blocking the pyrazinamidase. When you say dase, that's an enzyme, okay, into the pyrozonic acid. So the ethambutol, we don't know what the mechanism is, but it helps in attacking the TB bacteria. Streptomycin binds into the 30S. We already talked about this. So these are used for different types. Again, we can use it for long TB. We can use it for the plague, streptomycin specifically. We can use it for tularemia. Okay, this is actually a tick bite that you can get, and you can use it for endocarditis also. So, which is caused by tularemia, endocarditis, after endocarditis. So, second line of therapy for gram-negative bacillarly type of bacterium, meningitis, can be used for meningitis also. Okay, brucellosis, again, which is another type of gram-negative bacteria. It's not, granuloma inguinal. Again, we have one type of infection where we get granulomas in the inguinal region, and chancroid, which STD, we talked about it already, and UTI. So a patient must stay on these antibiotics for a duration of 9 months in order to be effective. So you can't stop. If you're treating patients for TB, you have to keep them on this for about 9 months. So if you test positive for TB, doctors will put you on these drugs for about 9 months. So you can't be discontinued for 9 months to take effect. Again, it's a regimen. It's a bunch of drugs together. They put all these drugs to treat TB. INH can cause tingling sensation on extremities, so CNS, hepatitis, GI loss of appetite, nausea, vomiting, and all that, rifampin, reddish coloration. This is important, so maybe it will be on your test. Patient will be peeing red color urine, so reddish coloration of the urine. So that's very important with rifampin. Pyrazinamide, symptoms of liver disease, jaundice. You can get jaundice. Ethambutol, with ethambutol, you get blurred vision, liver disease symptoms. Streptomycin, loss of appetite, which is very important. And then spinning sensation you get also from it. All right, so, okay, so this is the last two. We'll continue, we'll finish them so we can finish this. So these are new antibiotics that we have. We have the oxazolidinone, okay, zolidinone. So the oxazolidinone, linezolide, and tidazolide. So these are the two new drugs that are used for antibiotics. Again, this one, it inhibits the protein synthesis by targeting the binding of the N-formymethyl transferase. So again, it's a bacteriostatic. Okay, so bacteriostatic. So again, it works on the binding of the first. So formal methanol transferase, N-formal methanol transferase, is the first amino acid that goes to initiate protein protein synthesis. So this is the first amino acid, okay, that initiates translation proteins. So you need to put that on there first to initiate it. So if you have something that blocks this, so eventually you're not going to have this anymore. So, so that's one thing for sure. All right, so gram-positive vancomycin resistance, okay? So when you have Enterococcus faecium infection, this is important. If you are putting a patient on vancomycin and they are resistant to vancomycin, so that would be your choice. So linezolid, okay, would be the drug of choice.
Dr. J.
Yes.
Not that like I don't agree with it, but I had MRSA pneumonia in both my lungs and I was in the hospital for a couple weeks and they had me on Vanco, and instead of sending me home with a PICC line to run Vanco through, they put me on Zyvox, but I wasn't resistant to Vanco. But they put me on Zyvox for a couple weeks as like a continuation of Vanco instead of still like staying in the hospital. So
Okay.
I don't know.
No, this is fine. Exactly what you said. So we're saying that if vancomycin is not working, they put you on Zygo. So you're fine.
But
so
it
what
was
we did
working.
is, it didn't work or it worked?
It was working. And
Yeah.
so I was already in the hospital for a couple weeks, and because of the infection, they didn't want to obviously put a line in because of a high risk of infection. So they put me on an oral pill, which was Zyvox, because Vanco's not made for oral. But I wasn't resistant at all to Vanco.
Okay, so here's what we're saying here. You don't have to be resistant to Vanco. If you are resistant, this could be a good choice for you. That's what we're saying. So you don't have to be resistant. So if you are resistant to Vanco, so Vanco is good for MRSA, and then Zyvox is very good for MRSA also as a PO, right? So if you are resistant, then we put you on Zyvox. So they put you on both actually, so which is good, which is fine. So, but we're saying here, if you are resistant to Vanco, then this is a good choice, which they put you on both because you were not resistant. So they put you on vancomycin, and then they continued you as giving you this as PO, which is fabulous, which is right. So you're good. And that's exactly what I'm saying. I'm not saying anything different than was said. But if you were resistant to Vanco, then they put you on that. But they put you on both. So this is if gram-positive vancomycin resistant, then you can go on that. All right, so what are some of the side effects here? Diarrhea. Again, sometimes it gives you bloody stool, okay? Fungal infections, low platelets. So you have to monitor the platelets. Myelosuppression, vancomycin, so it's like vancomycin, it's very similar. Serotonin syndrome, so you have depression, nerve problems, skin swelling, angioedema, fever, chills, ache. So you can have any of these, or you could have none of that. Kylie, did you have any side effects at all?
No, I didn't.
Okay. So these are just possible side effects that you can get. Okay, so again, not anybody, the minimum you can get is probably a diarrhea, here and there or something. Okay, so Monobactam. Okay, now Monobactam is, again, it is a beta-lactam, okay, which is similar to the one that I mentioned before, but it is a new drug, and it is not, it's still used, of course it's used. When we say new drugs, we're talking at least 20 years, we're not saying like yesterday, but it's been going on. Very soon this is not going to be new drugs anymore. It'll be, so So manobactam, azactam is very much used. It's a bactericidal because it works on the beta-lactam, again, like penicillin. It inhibits the third and last stage of bacterial cell wall synthesis. So it works on the cell wall. Gram-negative bacteria like Pseudomonas aeruginosa is the drug of choice probably on this one here. Side effects, again, GI discomfort, injection, irritation, so nothing serious there. All right, daptomycin. Daptomycin, this is the one that works again on the cell membrane. Okay, so the cell membrane is inside the cell wall, remember. So the cell membrane is inside the cell wall, and what it causes rapid depolarization, resulting in the loss of membrane potential, and then that can lead to inhibition of the protein DNA synthesis, and which leads to the cell death. So here it works on the, causes the rapid depolarization of the cell membrane, of the membrane potential, and then it inhibits protein synthesis, DNA synthesis, and RNA synthesis. So it works on, it inhibits all these synthesis of all of the above. So daptomycin here. It can work on plaque also, you know, you can use that on plaque. Life-threatening infections caused by gram-positive organism. These are some of the side effects that we have. So muscle pain, numbness, tingling, tiredness, weakness, all that could be caused by daptomycin. Tigercycline is also new. Again, when we say new, it doesn't mean that it's not been there for a while, but this is actually a very good drug that is used for any bacteria that are resistant to Staph aureus, Actinobacter also, and E. coli. So Actinobacter pneumoniae, which is, you know, that is one of the, you know, the infections that are rare, and this is a good choice for it to be used, tigercycline. So this is for anything that is resistant, you know, to staph. So MRSA could be one of them, okay, that we can use it for it, but tigercycline. So again, serious bacterial infections. Okay, that's what we use it for. All right, adjuncts to antibiotics. We have, like I told you, these are stuff that we come and add on to like penicillins and so on, amoxicillins, synthetic ones, not penicillins, but synthetic penicillins in order to work on the beta-lactam. So these are beta-lactam inhibitors, for example, galvanic acid. So amoxicillin plus galvanic acid, which gives you augmentin. And this is usually, it works on the blocking the lactamase inhibitor in the bacteria. So we use that. Sulfamethoxazole that is added, and trimethoprim is used to add to, we create Bactrim out of it. It's you know, it's added to the sulfa drugs. So this one, it works on folic acid again, you know, like the sulfa. Here, they're just showing you that these are additions that we can add to antibiotics in order for it to produce better results and less resistance to certain bacteria like Staphylococcus bacteria here. We use that as a combo. Right, and then we have middle ear and all that. So this is used for UTI in general, intestinal, you know, so urine. So urine would be UTIs, so UTIs, you know. Right, diarrhea, pale skin, sudden weakness. You know what, again, it depends on the type of infection that you treat and the antibiotic that you add to. All right, so we're done. We're done with the antibiotics. This will be, I will post this, the updated one on Blackboard. So this is one of the chapters that we will actually have 2 chapters on the next test. So today's Wednesday. On Monday, I will cover antiviral. And then, you know what? Let me check one thing here. Okay, I'm going to stop sharing a little bit. I'm going to look at the test, what I have, or this. Well, actually, that's okay. Hold on a second. Let me check one thing here, because you can't see it anyway. So, you know what? The antibiotic is by itself, so we can actually have it earlier. I thought we would have also antiviral with it, but it's actually antibiotics only. So chapter 8 and 9, I think it talks about antibiotics. So let's have this test this weekend, and then I can have antiviral, anti-infective, antifungal together. Okay, so let's go ahead and all right, so let's go ahead and so anyways, I'm going to stop recording for now. So let's see here, stop video, stop recording. Yeah, that's fine. Okay, so I have to end it actually in order to